Hello to all. I am Vishnu. So in the past two videos, we were talking about drug mnemonics. So I just thought that I will bring a change in between. So today I'll be talking about Rntcp guidelines for tuberculosis management. This presentation will be divided into two parts because this is going to be a bit big. And we will talk about a newer molecule also, which has been introduced in India for the management of TB. So here we are going to talk about what do the guidelines say. Actually, Rntcp stands for Revised National Tuberculosis Control Program. So it is an Indian guideline, and it is a very, very comprehensive guideline which explains to you what are the treatment strategies for different types of tuberculosis. So we will go into that, but that will be divided into two presentations because this is going to be extremely big. A lot of things we will explain, a lot of things I'll talk here. And also for your information, those who are interested in tuberculosis, I will also talk about the pathophysiology of tuberculosis in another video, and also a lot of other things. So anyways, we'll go into that later. So if you look at the index, we'll have a general introduction. Epidemiological statistics. Actually, epidemiological statistics are not that relevant because it keeps on changing. Then we'll talk about the classification of anti-tubercular drugs based on Rntcp concept. So ATD means anti-tubercular drugs. We usually say ATT also, anti-tubercular therapy. Then we will be classifying different kind of tuberculosis cases based on Rntcp concept. Then there are different kinds of TB mentioned here, and what is the treatment strategy for those individual TB cases. So we'll talk about that. And if a patient is having ADR2 anti-tubercular drugs, what are the things that we can do? Anyways, we'll talk about this ADRs in detail and another video regarding anti-tubercular drugs where we'll talk about the practical catch points. And then we'll talk about Delamanid, which was introduced in India approximately 3 years back. So we'll talk about that as well. So this will be divided into two videos. So that is something that I want to inform you. So we'll come into general introduction. So Rntcp stands for Revised National Tuberculosis Control Program. This is actually an Indian government initiative for the control of TB, because you know very well the problem with TB is that it's a long-standing disease. And that is why most of the antibiotics do not work against Mycobacterium tuberculosis, because the outer surface or the outer coating of that bacteria is mycolic acid, and most of the antibiotics cannot penetrate it. And that is why this disease is very difficult to treat, and it requires extreme medication adherence and long-term treatment. Also depends on your immunity. If your immunity is very low and you got this disease, then the treatment duration can be further extended also. So that is why if you stop taking this medication in between, or if you take it irregularly, then this disease can be life-threatening also. So the main objective of Rntcp is to implement WHO guidelines for tuberculosis and DOTS therapy strategy in Indian scenario. So DOTS therapy actually aims at ensuring that if you are taking anti-tubercular drugs, you are taking it properly and you are taking it on a daily basis. So it helps in ensuring medication adherence. Epidemiological statistics. So as I said that this keeps on changing. So I have said the 2015 statistics here. So now it is 2022. So a lot of changes may have happened. So even if you want to, access the epidemiology, you can go to the WHO site. Maybe they have given some other updations. But according to the WHO estimates, 10.4 million people developed active disease. So 10.4 million is approximately equal to 1 crore 4 lakhs people. More than 1.8 million deaths occurred. That means approximately 18 lakh people worldwide had died from tuberculosis. And TB is definitely one of the top 10 causes of death worldwide. And if you look at the United States Center for Disease Control and Prevention, CDC statistics, 1/3 of the world's population is infected with TB. So this is literally very interesting. If you look at the population of the world, it is approximately 8.2 billion people. So if 1/3 of the world's population is infected with TB, if you divide 8.2 by 3, you are getting approximately 2.7 billion people who are affected with TB. So this is just an estimate. Obviously, we don't have the correct number, but this is just an estimate. But still, this is very, very alarming, because 1/3 of the world population is infected with TB means it's not a good news. TB represents a leading killer of individuals infected with HIV. Please remember this. If anybody is suffering from HIV, always remember the speciality of HIV infection. You will never die from HIV, but you will die from the opportunistic infections that happen due to HIV infection. Now, you know very well what HIV does to your body. It damages the CD4 T cell, which is also known as the helper T cell, which is important for your immunity. So when CD4 T cell count reduces, you start getting all kind of infections from outside. So you can get fungal infections, you can get other viral infections, you can get bacterial infections also. So if you happen to get tuberculosis and you are infected with HIV, it is going to be very life-threatening for you. And the treatment strategy for such people will be of an extremely long duration. Tuberculosis is one of the top 10 causes of death worldwide. In 2017, 10 million people, that is approximately 1 crore people, fell ill with TB, and 16 lakh people, or 1.6 million people, died from the disease. And out of that, 0.3 million people were those people who had HIV also. That means approximately 3 lakh people out of the 16 lakh people who died from TB also had HIV. In 2017, an estimated 1 million children became ill with tuberculosis, and 230,000 children died from TB, including children with HIV-associated TB. And as I said before, TB is a leading killer of HIV-positive people. Multi-drug resistant TB remains a public health crisis and a health security threat, because, you know, whenever you are having TB, the first thing that we see is which are the drugs that are sensitive towards that organism. If the first line agents are resistant, so it can be a single agent, it can be more than one agent, then we call as drug resistant TB. In multi-drug resistant TB, isoniazid and rifampin, both of them are resistant, and they are the most powerful first line agents. So that becomes extremely difficult to treat, because the second line or third line agents that we use, the efficacy is low and the side effects are high. According to WHO estimates, there were 558,000 new cases with rifampin resistance. So that is actually a special kind of TB which is known as RRTB. RR means rifampin resistance. And among the first line TB agents, rifampin is the most effective first line agent. And if that itself is resistant, again, that is another problem. But due to DOTS therapy strategy, or due to the aggressive TB control management, the incidence of TB is falling at about 2% per year. But again, remember, it is only falling at about 2% per year. The percentage should be much more significant, so that we can actually be confident about getting this disease eradicated. But again, it is very difficult. An estimated 54 million lives were saved through proper TB diagnosis and treatment between 2000 and 2017. That means 5 crore 40 lakh people's lives were saved. And definitely, according to the health targets of the Sustainable Development Goals program, the world is trying to, or the WHO is planning to end this epidemic by 2030. That means we are only 8 years away. But still, we usually get a lot of cases in which the child is having either pulmonary tuberculosis or extrapulmonary tuberculosis, whether it is a child or whether it is an adult. So the cases are still coming. If you look at the epidemiology in India, multi-drug tuberculosis is very common here, and the outcomes are very bad. In India, multi-drug resistant tuberculosis constitute 3% of all new TB cases and 17% of retreatment cases. Retreatment cases means earlier you had a tuberculosis in which isoniazid, rifampin, everything was sensitive. So you got treated. And again, the same infection came into you and multi-drug resistant happened. That means initially the treatment was sensitive to everything, but initially the organism was sensitive to everything, but then again when you got that infection, now multi-drug resistant TB happened. That is why in antimicrobial stewardship, or whenever we talk about rational use of medications, you know what happens, this is very commonly seen. Like for example, you are having a throat pain or you are having any kind of fever associated with throat pain. Instead of going to the physician, we usually go to the pharmacy. And what we do is the pharmacist will give you maybe an azithromycin or something, and he'll ask you to take it for 3 days or something. You are taking that medicine. The next day you feel that your throat pain is better. Maybe you took a betadine gargle also, or maybe a salt gargle, and you felt better. What we usually, most of the people, what they do is they stop taking the antibiotics after that because they argue that they are feeling better. Why should they take that medicine? But this is extremely wrong. Even if you are feeling better also, you should complete the course of antimicrobials because multi-drug resistant organisms, superbugs, are already on the rise. Next time when you have the same infection, maybe the normal agents that you could have easily used will be resistant. So that is why DOTS therapy is actually aiming at medication adherence. According to WHO's global report, India has the highest number of multi-drug resistant TB cases in the world. So this is the 2015 report. India has the highest number of multi-drug resistant TB cases, approximately 71,000 cases annually. In 2015, the WHO estimated 480,000 incident multi-drug resistant TB cases globally. So multi-drug resistant, as I said, both isoniazid and rifampin will be resistant. With an estimated 79,000 multi-drug resistant TB cases, India along with Russia and South Africa, they together contributed for 45% of the total MDR TB and rifampin resistant TB in the world. So this happened in 2015. In 2015, India along with Russia and South Africa together contributed 45% of the total multi-drug resistant cases in the world. So this is the condition now. So now we'll come to the classification of anti-tubercular drugs based on the Rntcp concept. We usually have a pharmacological classification that you can refer the pharmacological textbooks. This is based on the Rntcp concept. So according to Rntcp guidelines, anti-tubercular drugs have been classified into 5 groups. So first we'll talk about group 1. So these are the first line oral drugs. Please remember, this is the Rntcp classification. Group 1 are the first line oral drugs. So they are the most potent medicines and they are the best tolerated oral drugs. Always remember, first line oral drugs are best tolerated and they are the most potent. So they are usually used routinely because they are the first line choice. So the drugs include RIPE. So you can use a mnemonic for this, RIPE, RIPE. R stands for rifampin, I stands for isoniazid, P stands for pyrazinamide, and E stands for ethambutol. Let me tell you some interesting facts about these medications. Anyways, I'll come to this in detail in a separate video on antitubercular drugs, where I'll talk about a lot of interesting things that you may have missed when you studied or you may not know. Isoniazid can cause pyridoxine deficiency, that is vitamin B6 deficiency. And if vitamin B6 is deficient in your body, three things can happen. Always remember, there are a lot of other issues with pyridoxine deficiency. But if pyridoxine is deficient in your body, three things can happen. Number one, peripheral neuropathy. It is extremely, extremely painful. Peripheral neuropathy means you can have burning sensation or paresthesias all over your body, and you cannot predict what is the reason. It is like somebody has ignited a fire in your body. Always remember, damage to your nerve is called neuropathy, and that is extremely painful. Isoniazid causes vitamin B6 deficiency, so that can also result in seizures, especially if you are using in toxic doses. If pyridoxine reduces too much, it can result in seizures. There are a lot of cases in which we have seen in which isoniazid-induced seizures have happened. And then midazolam infusion had to be given, levetiracetam had to be given, etc., etc. If pyridoxine is less in your body, it can also cause mood disturbances, irritability, aggressive behavior. This is actually a side effect which is seen with a very interesting medicine, which is an anti-epileptic as well, and that is called levetiracetam. If you look at the side effects of levetiracetam, which is a very commonly used anti-epileptic, whether it is a pediatric or a geriatric or an adult, you will see that the side effects in that it has been written, it can cause irritability, mood changes, aggression, etc. So I was just investigating the reason behind it, and then I found that it reduces pyridoxine, which can cause this. And that is why patients under levetiracetam therapy should be advised, because obviously you'll be taking it for a long term, so should be advised to increase your intake rich in pyridoxine rich diet. Anyways, I'll talk about that later. Rifampin can cause renal failure. It can cause discoloration of urine. So we should advise the patients that even if your urine is discolored, don't feel afraid and stop the medicine. It is just a natural process and it will get resolved very soon. Rifampin can cause thrombocytopenia. So it reduces your platelet count. So if you are using rifampin with any kind of antiplatelet agents, so there can be an additional risk of thrombocytopenia because the platelet count may further be reduced. Pyrazinamide, usually it is also to some extent hepatotoxic. Anyways, the first line agents are hepatotoxic to some extent except ethambutol. Pyrazinamide can cause it to some extent, and pyrazinamide has another speciality. We'll talk about that later. Whenever we talk about the treatment of tuberculosis, we have an intensive phase and a maintenance phase. Intensive phase means we are aggressively treating the disease, and maintenance phase means if any organism is still remaining in your body, we have to wash it out. So pyrazinamide is usually not used in the maintenance phase. It is only used in the intensive phase. Now let's talk about ethambutol. Ethambutol should never be used in any children below the age of 5 years. Let me explain why. Because ethambutol causes optic neuritis, inflammation of the optic nerve. Always remember, if the nerve is damaged, it is almost irreversible. So if it is a child below the age of 5, the child will never be able to say that he or she is experiencing blurred vision. If it is an adult, it is not a problem. They can at least speak. But if you are giving it to an infant, or if you are giving it to a child below the age of 5 years or who cannot speak, the parents will also never understand that the child is slowly and slowly getting blind. So ethambutol should never be used in two kinds of patients. Number one, patients who are unconscious. Maybe they are admitted in the hospital or they are under ventilation and you are giving ethambutol. No, it should never be, because they are already unconscious. So how will they report that they are having blurred vision? And definitely in children below the age of 5 years. Because we usually consider that at least up to the age of 5, the child will start talking. But below the age of 5, it is always a risk factor. Now we come to group 2, which are usually known as injectable drugs. So group 1 were oral drugs, first line agent. Now group 2 comes injectable drugs. They are usually potent in nature. They are bactericidal in nature. And they are definitely injectables in nature. So you can use a mnemonic for that, and that mnemonic is known as SACK, S-A-C-K. S stands for streptomycin, A stands for amikacin, C stands for capreomycin, and K stands for kanamycin. So usually you have understood that group 2 agents are known as aminoglycosides. But again, as I said, aminoglycosides are nephrotoxic in nature, they are ototoxic in nature, and they may cause neuromuscular blockade also. So we should be careful about that. We should monitor all those things as well. Group 3 are known as fluoroquinolones. So they are well tolerated, bactericidal oral drugs. So these are the second line oral drugs. First line oral drugs, I already said, they are RIPE. Second line oral drugs are fluoroquinolones. According to the Rntcp guidelines, all patients with drug-resistant tuberculosis should receive one fluoroquinolone. Whether it is whatever kind of drug-resistant TB it is, you should receive a fluoroquinolone unless and until it is resistant. So you can use a mnemonic CLOM, C-L-O-M. C stands for ciprofloxacin, L stands for levofloxacin, O stands for ofloxacin, and M stands for moxifloxacin. But I usually prefer that levofloxacin and moxifloxacin should be used in patients with tuberculosis, and I'll explain you why. Levofloxacin and moxifloxacin are also known as respiratory fluoroquinolones. Respiratory means they have maximum effect in the respiratory tract. And you know very well that tuberculosis is a respiratory disease. So levofloxacin and moxifloxacin you will commonly see in the treatment regimen of patients with tuberculosis. But again, they have their own share of problems also. Higher the generation, higher the risk of QT interval prolongation. So moxifloxacin is a higher generation. Levofloxacin is also a higher generation. There is a risk of QT interval prolongation. So you cannot use it with other medications which prolong the QTC interval. And definitely they cause myopathy. They can cause tendinitis, inflammation of the tendons. So we usually advise the patients, if you are experiencing palpitation, unexplained palpitations or chest pain, which is an indication of QT interval prolongation, or if you are experiencing muscle pain for no reason at all, then definitely you should report to the physician or pharmacist. Now we come to the group 4 agents. They are the second line oral drugs. They are less effective. They are bacteriostatic in nature. Please remember, they are bacteriostatic. Bacteriostatic means they only prevent the growth of the organism. They do not kill the organism. They are more toxic than first-line oral agents. But we usually use these agents if you are having multi-drug resistant tuberculosis or extensive drug resistant tuberculosis. Then we don't have any other option. We may have to use them. So those drugs include ethionamide, prothionamide, cycloserine, terizidone, para-aminosalicylic acid, rifabutin, and rifapentin. So there is a mnemonic that I explained here, PPRRECT. So double P stands for para-aminosalicylic acid and prothionamide. RR stands for rifabutin and rifapentin, and E stands for ethionamide, C stands for cycloserine, and T stands for terizidone. Group 5 are the most toxic agents with the least efficacy. They are also known as unclear efficacy drugs. So you can use a mnemonic CCC-LIB. So the C stands for clarithromycin, which is a macrolide antibiotic. Another C stands for clofazimine. Clofazimine is very interesting. It is actually a drug which is used in the treatment of leprosy as well. Another C stands for co-amoxiclav. So co-amoxiclav means amoxicillin clavulanic acid. You know that. L stands for linezolid. It is an oxazolidinone antibiotic. I stands for imipenem cilastatin, which is a carbapenem, and B stands for bedaquiline. If you talk about interesting features about linezolid, it usually causes lactic acidosis. So you should be very careful if you are using this medicine in a patient who recently suffered a heart attack or a myocardial infarction, because this medicine can cause lactic acidosis as well. It can also cause, to some extent, it can cause damage to the bone marrow as well. So frequently we should check the blood counts. If you look at imipenem cilastatin, imipenem is actually a carbapenem. The problem with this drug is that when this goes into the body, there are some enzymes released from the kidney, which is known as renal dehydropeptidase 1. That enzyme breaks down imipenem, so we don't get its benefits. So what we do is we give a molecule known as cilastatin, and this cilastatin, what it does, it prevents that enzyme, renal dehydropeptidase. So as a result of which, the efficacy of imipenem will be sustained. But again, imipenem cilastatin has a problem. It can precipitate seizures because of the cilastatin component as well. So we have to be very careful if we are using this molecule in a patient who is suffering from seizures. Now let us classify some TB cases based on Rntcp concept, which are the different kinds of tuberculosis. So first we have drug-sensitive tuberculosis. So this is very simple. The patient's bacilli means the organism. Mycobacterium tuberculosis is actually a bacilli. It's a rod-shaped bacteria. So in this case, the patient's bacilli is susceptible to all first-line drugs. So this is very easy to treat. So such patients may include newly diagnosed patients. That means they are having tuberculosis for the first time in their life, or patients pre-treated with tuberculosis in the past. For example, you already had tuberculosis in the past and you got it again. But if that bacilli is still sensitive to all first-line agents, you are very lucky. You can be treated very easily. Multi-drug resistant TB is very dangerous. In this case, the patient's bacilli is resistant to both rifampin and isoniazid. They may or may not be resistant to other first-line antitubercular drugs. So the criteria for multi-drug resistant means isoniazid and rifampin both should be resistant. Then we come to rifampin resistant TB. In this case, the patient's bacilli is resistant to only rifampin and not isoniazid. That is why the name itself is there. So if you get a Gen Expert test, or if you get any kind of test of tuberculosis in which it is mentioned that only rifampin is resistant, then you should mention that TB as RRTB. That means rifampin resistant TB. The bacilli may or may not be resistant to other antitubercular drugs. Then we have monodrug resistant TB. So in this case, the patient's bacilli is resistant to any one first-line agent except rifampin. So it can be isoniazid, it can be pyrazinamide, it can be ethambutol. So if that bacilli is resistant to any one of the first line agent, because its name is mono. Mono means single. So that is called mono drug resistant TB. We are not mentioning rifampin because if it is rifampin resistant, then we call it as RRTB. Then we come to polydrug resistant TB. In this case, the patient's bacilli is resistant to more than one first line antitubercular drug, except rifampin and isoniazid. Because if it is rifampin and isoniazid, we'll call it as multi-drug resistant TB. So if the patient's bacilli is resistant to more than one first line antitubercular, so for example, the patient's bacilli is resistant to pyrazinamide and ethambutol, so we can call it as polydrug resistant TB. Extensive drug resistant TB is the most dangerous TB. In this case, the patient's bacilli is resistant not only to first line agents to some extent, but also resistant to a fluoroquinolone. FQ means fluoroquinolone, and a second line injectable antitubercular drug. So the treatment strategy for extensive drug resistant TB is very complicated. We'll talk about that in the future class tomorrow. So tomorrow I'll be talking about the management of different kinds of TB. I'll also talk about how to manage the ADRs that may happen with first-line antitubercular agents. And I'll also talk about delamanid, which is a newer molecule that has come in India, and what are the interesting catch points associated with it. So that's it for part 1 of Rntcp guideline video today. I hope you have got some of the interesting informations that I wish to share. If you appreciate my efforts, then please do subscribe and share to maximum people. Because as I always say, knowledge is power and knowledge shared is knowledge doubled. So thank you so much. I'll meet you tomorrow with the part 2 version of Rntcp guidelines. Until then, it's good.